All right. Well, hello, everyone. We're going to keep going here. My name is Dr. Brittany Volk. I am an associate director of clinical research here at Virta Health, and I will be kicking off our first session of the conference focused on innovative chronic care models. Now, why this topic? Well, I think it's no secret that the COVID-19 pandemic drastically accelerated the adoption of telehealth and virtual care models. Looking forward in the years to come, how can we leverage innovative new technologies and data to truly, transform the provider-patient relationship and reverse the progression of chronic disease? Now, this philosophy lies at the very heart of Virta's diabetes reversal treatment. Before we dive deeper into the larger panel, and as we wait for more guests to join us here today, we have a surprise guest who will be joining us for about the next 10 minutes. Heather Angel, a patient here at Virta who will be sharing her personal journey on how Virta's care model has personally impacted her life. Heather has been a patient with Virta Health for 3.5 years. And just wait until you hear not only her many wins with Virta, but also her commitment to this lifestyle that's supported by Virta's unique care model. So Heather, thank you so much for joining us.
Hello, Oscar Wikwasan is hello in Naha Higansa. Dr. Brittany, it is a joy to be with you and share a portion of my story with everyone. I know Virta was introduced to me through my employer 3.5 years ago. A simple email. I think about that simple email, a click of a button that was shared with me by a coworker who happened to be my brother. I give him all the credit. And in reading it, just toying with the idea of Virta being able to help guide and direct my path to reversing diabetes. It didn't seem possible, but it certainly seemed worthy of checking out. And I think about that day, those weeks, and after living with diabetes, at that point, it was 17 years, and on insulin all of that time. I remember first the onboarding, trying to understand how I'm going to use food as medicine, this new idea of nutritional therapy, and how it was foreign to what I had already been taught and was practicing. And I keep going back thinking about what was different about that encounter with Virta. The difference, Dr. Britt, was I was given a choice. I was given a choice in my treatment. Can you imagine? We take things for granted. We hear something, diabetes, once you're diagnosed, I believed was a lifelong sentence, if you will, to the ills of the disease. But Virta taught me something new. It taught me something that I hadn't been exposed to before, that if you, with us, because Virta has held my hand for 3.5 years in a sense, by just being that support through contact with my doctor whenever I need him. I was thinking before Virta, I think I saw my doctor twice a year. Great person, great team, but it wasn't what I needed to change my health. And then I think of Virta's introduction of a health coach. For 3.5 years, I've had someone I could reach out to for guidance and direction and encouragement. I think those two keys has definitely made the difference in my health journey over these past 3.5 years of finding success, of finally getting that A1C down 3 points, not 1.5, but 3. And so before I get carried away, Dr. Brittany, please, because I can. Once I start talking about Virta, I don't know where to draw the line.
You don't have to draw the line at all here, Heather. Not to live too much in the past, but of course you had diabetes for 17 years. So thinking of where you are now with Virta, how has life changed? And some of that, tell us a little bit about before, but then let's live in the present. Tell us about now.
So yes, certainly living before was the rat race of insulin and highs and lows, and that there's no quality in living that style of managing diabetes. There just isn't. But now that I've learned how to use food as medicine, I haven't had a single low and I haven't suffered from a single high since changing my nutritional intake, using nutritional therapy to actually meet my body's needs, learning how my body responds to certain foods in a way that I had never explored before. And the motivation behind me making it down this path for 3.5 years is never experiencing a low. And I think of the many times I did and how that slowly eroded my lifestyle. I love being out there and being involved in so many things, but lows kept me more and more at home because it's scary. You don't want to put anyone out. You don't want to be out in public and not be able to manage your own self. All that's gone now. I'm back out on bike rides in groups or alone. I travel across. Yeah, and I'm able to travel through, and now that we're at a safe point in time with our vaccinations and feeling safe to do so without that fear of the stress of just traveling, being a hindrance on how my body's going to respond with highs and lows. So I actually feel as though with the guidance provided to me through both doctor and health coach, and my own commitment level, that the quality of my life has increased tenfold. I'm not ashamed to say it because many of us don't make it. I just turned 57 a couple of weeks ago. And at this age, I feel younger and stronger and more capable than I did 20 years ago. So I've been given a gift of health. My heart sings differently. It beats differently. I'm able to give a level of energy to those that I love in my circle and my family and my passions and hobbies and work. They have all benefited from the increased energy and just overall health and well-being. You feel confident when you're not worried about how's your body going to respond in this moment of excitement or stress or wrong choices even. So yeah, life has definitely improved.
So I have a two-part question. One is, I don't know that everybody on this call can truly appreciate when you say, I haven't had a low, what that means for you. And then, you said not having to rely on my family for if I have a low. How has how you've relied on your family changed, or how has their support from before Virta to throughout Virta really changed for you? So two-part question.
So help me if I get too far into one, bring me back. But to give you an idea of what a low meant is when you're taking insulin continuously, and for me it was years, sometimes it just becomes like a habit. You're not even thinking anymore. You're just going through the motions. And at the time, I remember being given a food diagram, like you eat so much carbs and this and that, and you'd follow that. And I would take my insulin to respond to what I ate. And activity, stress, joy, all of those things has a profound impact on my body. And there would be times where I would have this low. And what that meant for me was my blood glucose levels would drop. And it would drop dangerously, so that I would require sometimes and oftentimes assistance in getting that blood glucose level back up. If I was alone, it was scary. There was a frightening happening for me where it was just late in the day. I had dinner and I had taken my insulin more than was required at the dinner time because I actually dialed up a bedtime dose, and I had given myself more insulin because I was on now 2 different pens. And that mistake wound me up in the emergency room fighting to come back to myself. And I think of the stress and the fear that puts on my family and my husband at the time, and all of us just really wanting out of this madness. And I say, because when you watch a loved one suffer with diabetes and you don't know how to help them, I couldn't speak sometimes. I would fumble over my words. I couldn't get a thought out. And just the fear in your loved one's eyes, the fear in my own spirit was just terrible. So now that I don't need to rely on insulin, that I no longer have those lows, I rely on food as medicine. So my family is free from worrying about me not being in a safe place. They're free of worrying when we go out on a bike ride, is she going to be okay? Is she going to make it back home? And my family has been freed up. My loved ones, I have been freed up from battling those lows and highs.
Oh, I'm so happy for you, Heather. I know that you've already touched so much on this, but to wrap it up, can you just tell us a little, summary of how your life has changed and, how has, what you've achieved impacted, your mission here today?
So, I absolutely feel a level of responsibility to share the knowledge of Virta with anyone I come in contact with, especially throughout home. So my parents' home, my children's home, my daughter-in-law, whenever I fly out there, it's all recipes of Virta. So my brother, who is the one who shared that initial email with me, watching his health improve as well, just by taking simple steps of understanding what food does to us, how we respond to it. I'm sort of like, this is what I say, that we can't always force someone to hear a message, but we can plant a seed. So when I think about that, I think how Virta is out there across this nation planting seeds. Like, you can have a choice on your health journey. You could choose to take both reins with guidance and direction and live a life full of quality, or we could choose to rely on medications and insulin and not really focus too much on nutritional therapy. And the power that they gave me was the power of choice. So whoever decided to roll this out to our employee base, I wish I could see them and look them in the eye and say, thank you. I didn't know what I was capable of. I didn't know that 3.5 years down the road, I would still be on this journey. That is a lifetime journey for me. But someone opened the door for that to happen. And it all started through my connection, through my employer, Virta. And I'm indebted forever. I have a quality of life back that I wouldn't trade for anything.
Thank you. It is always an honor speaking with you, and your story, I don't think it's a surprise to anyone here that it continues to inspire us here at Virta and thousands of people around the world. So thank you for helping us plant the seed. Up next, I would like to give a great big welcome to our panelists. Dr. Joshua Riff, founder of Included Health, is a serial entrepreneur. Dr. Riff founded EHIR, formerly the CEO of Onduo. Dr. Robert Groves is Executive Vice President and Chief Medical Officer of Banner Aetna. He's not only a trusted healthcare technology leader, but also a published author, speaker, and creator of the Groves Connection podcast. He also serves as an advisor to Microsoft. Dr. Anthony Nguyen, Chief Clinical Officer of Elevance Health, is a seasoned healthcare executive who previously held leadership roles at United Health and Kaiser. So again, a huge welcome to our special guests. Over to you, Dr. Riff, to kick off the panel.
Thank you so much. So the discussion today is on reversing chronic disease through new care models. And what's really interesting about this is to key on the term reversing. I think for the last 8 to 9 decades, we've been managing chronic disease. And it's interesting that in this Moonshots conference, we're talking about reversing chronic disease. So I'd like to open it up by saying, what's different now? So we completely transformed how we deal with acute episodic disease with the inventive antibiotics. When we look across the industry today, we're reinventing the way cars work through batteries. We've reinvented convenient purchasing through our iPhone with things like Amazon and Uber. But I'd love to ask you, Robert and Anthony, today, why are we talking about treating chronic disease differently? And then why today do we have the potential of having a reversal moonshot? So Robert, how about I start with you?
Oh, okay. Thank you, Joshua. One of the things that impressed me when I first saw the Virta Health program, I was skeptical like everybody else when I first saw the term actually in writing diabetes reversal. It's like, how is that possible? And as I got further and further into the program, I started to understand how it's possible. And I think the point that is often missed when we talk about Virta Health, sure, I mean, metabolic disease is a huge problem in this country. Half the population suffers from some manifestation of metabolic derangement, whether it's the metabolic syndrome, obesity, prediabetes, or diabetes. And, not to mention the downstream health problems that go along with that over time. But what really impressed me is the care model that is being leveraged to deliver this care. And that, to me, is as important, if not more important, than the results that they're getting with diabetes. And believe me, I think that's incredibly important. But what I mean by that, and Virta has coined it as continuous remote care, is it brings together all the aspects of human nature, frankly, into a coordinated program that allows what was formerly thought to be impossible to be possible. And, we've known for a long time that controlling the carbohydrate load can have a profound impact on blood sugar. It's almost common sense. But there were two things standing in the way. One is nobody believed it was possible to stay on a low enough carbohydrate diet to sustain it. And there were questions about, would it be okay? Is it going to be safe? And then the second thing is once somebody's already diabetic, messing around with the average carbohydrate load, reducing that load, can lead to the types of drops in blood sugar that Heather was talking about earlier. So those were the two barriers. And what Virta Health has managed to do through the development and deployment of a new care model is address both of those, and then with some added features. And when I talk about this, I talk.
Sorry to interrupt. So specifically, we'll get to Virta.
It happens to me frequently, Joshua, don't you?
Yeah. But for this time, pull out from Virta. It's 2022. What is different now that we could actually transform care models for chronic disease? Give me one or two things that are different.
Absolutely. Technology is what's different. The ability to have two-way communication 24/7, whether it's for lab values or other metrics or just questions that a patient may have about their care. That's one thing that's different. The other thing that I think is different is now that it's been proven possible to reverse disease, we know that we have that option. But the other thing I want to bring in here is developing the why. This is known as motivational interviewing, is part of the upfront onboarding in a very clear but clever way. And then community, the fact that there are now readily accessible online resources for self-teaching recipes from other folks who are in the program, the ability to connect with them, you can ask questions, and those things address all of those needs. Having a health coach readily available very, very quickly is also part of that. It's not so dissimilar for what CMMI designed for the oncology care model. The availability of somebody to help in real time when questions come up.
Terrific. Dr. Nguyen.
Yeah, we don't overcomplicate things at my company. And the key is it's about relationships and it's about empowering people. And so what I mean by relationship is when we assign coaches to our members, it's not just the next nurse that's up and available. Here we're using AI to be able to pull in information about Josh, all the information we know, and then using our patented process, similar to Match.com and eHarmony, to match the member to the right nurse and then have that connectivity. And then once you have that connectivity, that's where the magic happens. They're inspired because they want to be your friend. Just like when you have a connection with the doctor versus somebody that you don't really care for, then that leads them to build trust, and that leads to compliance, and it leads to this curiosity to learn. And that's really where we start off. We start off with relationships, and so we engineer that, similar to how when people get married through these dating channels, the divorce rate is much lower. So unlike meeting people at a bar, we kind of engineer it now.
That's awesome. So I'm hearing community, some advancements in psychology, definitely technology, AI, and don't date in bars, date online is what I'm hearing. That's my big takeaway here. Anthony, you've literally been at the helm of some of the biggest companies in healthcare. You've seen a lot of trends over the last decade or so. In the last, call it 2 to 5 years, what are some of the most important trends that you've seen on the healthcare delivery side? And then how are those trends going to continue into the future and change the way we manage chronic disease?
Right. So it's first about building trust, building relationships with establishing relationships. So that's number one that we focus on. The second is, like what Robert mentioned, access. So we have availability for our nurses to be able to, our members to access their health coach, texting through video channels and such. But also, more importantly, it's the ability to now give them information that is practical. Because like when we talk about carbohydrate load and all these other things, we complicate the shit out of things. And that's what members just don't gravitate towards that. And that's the problem that I see, is that we take these really bright propeller head scientific people and then they go off and do these crazy evidence-based programs, but it's not meaningful. So over the last 5 years, I think people are starting to now grapple and accept consumerism and focus on what the experience. And so that's what successful companies do. They focus first on the experience and then add in the scientific stuff.
For sure. Dr. Groves, what are your thoughts? What are the most important trends you've seen over the last 5 years, and how's that going to affect the next 50?
Yeah, I think there are so many trends happening, and not least of which is large entrants into the healthcare market, like Walmart and Amazon and CVS, and I think they will be a force to reckon with. The long-term deal that we just heard about between Walmart and United Healthcare, for example, is a fascinating development. Now, some may say, well, these large companies have failed multiple times, but often that's how innovation looks. They're testing models and theories to see if they can get into the game, and the incentives are incredible for disruptors. You think about it, we spend almost $4 trillion on healthcare. If you roll that out in seconds, it would take you about 120,000 years to watch 4 trillion seconds go by. It's almost an unimaginable amount of money. And a number of companies have discovered that there is a possibility to get a piece of that, and that's what's driving a lot of the incentives. One hopes that if any of those models get traction, that what they do then is what they've done in other industries to an extent, which is bring down the cost. That's the part that we keep waiting on. And certainly, all of our analytics have done a great job of pointing us in the right direction, but we're starting to understand that that doesn't help us if we don't understand how to influence patients. And I agree with Anthony that one of those big prime influencers is a relationship with a trusted advisor of some kind, and typically that is a physician or a nurse practitioner, but it can be anybody on that person's team as well. We've gotten away a lot from the notion of good primary care in this country, but I still believe that it's going to require, as Anthony said, a relationship in order to bend behaviors towards health. And, that starts with a model that's effective at both delivering those services to patients in real time where they live, which is often at home and on their mobile devices, and backing that up with technology that allows them to make a connection and to engage in managing their own health. And Anthony's also right in that simplicity gets the job done. But we've really got two audiences. The other thing that's changed over the course of the last few years is physicians are recognizing that the science does exist to support some of these notions, such as reversal of diabetes, such as using insights into human behavior to influence behavior towards the positive. So I think there are a lot of things that are lining up. You know, we're all waiting on the promise of genetics, and I think we'll get there. As we've gotten into it, we've understood that it's really complicated and that it's not going to be simple or easy. But progress is being made on all of those fronts. So I'm very optimistic about the future. If we are wise and move forward with these models that have been demonstrated to work, we believe that there's 30 to 50% of that $4 trillion that's wasted today, and that's an astonishing number. But many believe that to be true, and I'm one of them.
Yeah, I'm still trying to get over watching a movie for 1,000 years on that. Let me ask you guys both a question, because you are both clinicians and now you're both on the other end where you are providing health insurance. If I had a magic pill that could reverse a disease, you guys would love it. Insurers would love it because it saves money. But as a physician, the incentives are a little perverse, because the more times I come to visit you as a doctor, the more I make. And that's why, like, not to pick on doctors, but maybe I'll pick on an orthodontist. Orthodontists love coming in for braces adjustments because they get paid every single time. So they keep encouraging that, come back every 6 weeks. What are you guys doing to try to incentivize physicians and the practitioners who are actually seeing the patients to focus on prevention and reversal, despite the fact that it could cost them a lot of money, but it could save you a lot of money? So Anthony, why don't I start with you?
Yeah, so great question. I mean, we all talk about value-based care, but when you still look at the amount of money being paid in healthcare, the trillions of dollars, vast majority is still being paid in a fee-for-service environment. So we're still far, far off from that. So that's the challenge that we have. So what do we do at Elevance? Clearly, driving value-based arrangement is a big priority, and then not just putting payments through a value-based arrangement, but we look at it from what is the shared savings that is generated, because then it's a win-win for us and a win for the provider. That being said, the vast majority is still being fee-for-service. So what we have to do is, yes, continue down the path of a value-based arrangement, but then also focus on what is right for the consumer and the patient. So we have, irrespective of the value-based provider or not, we still have nurses that are designated to that practice. So we don't care if you're in a value-based arrangement or not. We know, and from our relationships with providers, that they want to do the right thing. So we take the high road and we appeal to them. And I think most doctors and health systems are genuinely interested in doing the right thing. So we take the high road, and we've been getting a lot of traction with that still.
That's terrific. So incentive design, payment reform. Robert, what about you guys at Aetna Banner?
Yeah, we are following the model of attempting to incentivize those kinds of behaviors that reduce cost over time. If we're going to be honest, we have to say that it's tough, particularly on the commercial insurance side, because turnover is so rapid that companies are reluctant to invest, a lot of money in a strategy that won't pay off for 10 years. So we've got to find some way to spread out that risk and that benefit over, the landscape. And in other words, so that there's more incentive for us to do more, frankly, in terms of preventing long-term risk. Now, when you have something as difficult as diabetes is, you get a pretty quick ROI on that, and so that's why it's of interest. But even in addressing the administrative complexities, there's a lot to be gained there as well. I think over the long term, we need to get to something that is much closer to capitation, because even though value-based arrangements today are different than straight fee for service. In other words, there's an amount held back, or a bonus, if you want to look at it that way, that's paid out at the end of the year if you hit these quality targets. The problem with that is that the system is still based on fee-for-service, so there's still an incentive to do more, to provide more. And physicians are no worse than anybody else, but at the margin, when the incentives, particularly financial incentives, are in play, it does have an influence on behavior. We know that. The other thing that I would say is we have to be careful how we're using metrics and how we reward and punish with metrics, because the data is pretty clear on that as well, that can be detrimental to intrinsic motivation, can be alienating and dehumanizing. So we have to be really thoughtful about this transition, but ultimately what we need to get to is a system that pays me as a physician to do what I love to do and am intrinsically motivated to do, which is take really good care of patients throughout their lifetime. And capitation is much closer to that than anything that is common today.
Yeah, so let me stay on the reimbursement theme and pull on a thread. So if I invented a pill that could reverse diabetes or manage blood pressure, decrease depression, chances are it's going to get FDA approved and then it will get covered by insurance. If I create a digital therapeutic, though, that could get the exact same outcomes as that drug, I have a very, very different path. So from your guys' seat, I think nobody in the country probably has more authority or power or be in a position to actually make decisions like this. How are you guys viewing digital therapeutics? So if I could produce an app that has similar efficacy to a drug, how do you guys individually, and then how do your organizations look at those types of inventions? Robert, we'll start with you.
We are very much into digital therapeutics, and even before the pandemic, we had said that our areas of focus for the next couple of years, at least, will need to be metabolic disease and behavioral health. And by the way, they're interrelated significantly. Stress increases the challenges with metabolic disease, et cetera. So we started to approach both of those, and we quickly realized that there are going to be challenges with navigation. Currently, we have a very, I think Robert Pearl has called a middleman mindset. And we have all these point solutions. Well, we need knowledge management on top of that in order to get the right solutions to the right patients at the right time without confusing them. We have to simplify it for our members, so if they're having a crisis in behavioral health, they know where to go, and they can, by answering a couple of simple questions, very quickly see what options are available to them and how to access those options. It shouldn't be this difficult to navigate the healthcare system, but it is. And so providing that kind of help is a big step forward, I think, and something we're very much focused on going forward. And then, finally, from the delivery side, from the financing side, however you want to look at it, we got to make it so much easier for patients to interact with us and understand what they're paying and why. And I think we're getting there, but we've got a few more steps to take in order to slow this train and actually get us engaged in what we ought to be doing. By the way, we value rescue medicine in this country extremely highly. And so when you talk about a pill or those types of things, those really are rescue strategies, if you will, because the horse is already out of the barn and you're trying to save the day with a pill. Now, what we've learned over time is providing a pill doesn't often solve the issue completely. So first of all, I would be skeptical that there were no consequences to that strategy. So we are bullish on digital therapeutics, and we're even going to have the ability for our docs to prescribe digital therapeutics with a digital formulary, if you will, that's accessible to them at the time they're seeing members.
Can you tell us one or two companies or digital therapeutics that you're covering currently, or that you plan on covering?
There are over 20 behavioral health strategies that are out there. Companies like Able to. Actually, the digital therapeutic that's going to be in that digital strategy as well is going to be Virta. But there are countless numbers of companies that can be in that portfolio.
That's
we have
awesome.
actually a physician group that reviews each of these and determines if they're appropriate and vetted so that they can be provided to patients through that digital therapeutics pharmacy, if you will.
That is awesome, and that's super innovative, probably a topic of its own. Anthony, how are you guys looking at digital therapeutics, and would you cover them or reimburse them in the field?
Yeah, so absolutely. We're agnostic whether it's a pill or a digital solution, but we approach it differently. So, I shared with you the consumer connection that we're focusing on, as well as the experience. So one example is with our digital therapeutics that we have, whether it be Crohn's, diabetes, hypertension, it is focused around personalization. So for instance, you can download our app as well as Robert. You will each get different messaging because then we have 5 archetypes that we've broken down. And so now the messaging that comes out to you, Josh, versus Robert is completely different because our personalities are different, as one example. So we use personalization AI to drive that. In addition, the multimedia that we use, it's not just, a bunch of boring health, related topics or writing. It is snippets. And so the videos that we use, we curate as well. So similar to TikTok as well as YouTube, we identify and see what resonates and what the adjacent learning opportunity is to feed that. And then we measure that. So again, we are adopting a consumer mindset, much different from traditional health companies that, want to buy this vendor, that vendor. That ecosystem is something that we really focus in on, in that experience.
Terrific. Thank you. Great answers. So switching gears for a second, my background, I started my first real non-clinical job was at Target. And one of the things that always impressed me with retail is they meet the consumer where they are. So Target loved their stores, but they understood that consumers wanted to buy things online, and they came up with a strategy called bricks and clicks. And you now see Amazon that was just clicks, now bought Whole Foods, and now they're doing bricks and clicks. They'll do the same thing with One Medical and probably PillPack at some point. Despite all of these advancements, though, in virtual and hybrid care, I still see a lot of friction in the system. When my kid, cut his forehead, I still had to go to an urgent care and get those stitches versus figure out a different solution. So as physicians and then as healthcare leaders, what friction are you seeing? And if you could point to 1 or 2 problems that said, if we could fix this consumer engagement problem, or if we could fix this access problem, we could kind of leap step into that moonshot territory. So Anthony, why don't we start with you? What are a couple problems or friction points you're seeing that really are preventing us from getting to this next level in new care delivery?
Yeah, so the first one is just trust. I mean, being from the health plan, your finance and care providers don't trust you. But when we now start working in collaboration and have a higher level of trust, we can take away those pain points. One example is utilization management. Prior auth, big pain in the ass. Well, providers love to fax us. They fax us things that are half-baked. And then we have to deny it because we hit a time frame. Well, we work with a lot of providers, and now we go out there and say, hey, I'll give you a performance guarantee that we will reduce your denial rate if you give us access to your EMR. And lo and behold, the lack of information denials drop. That's just one example of the pain point where we have knowledge workers, that nurses and doctors that don't have enough information and that they are working in a vacuum. So my point is trust and then sharing information in the ecosystem drives much better results. So that now when I call Josh from the health plan to coordinate his care for his diabetes, I know exactly what's going on. Simple things like that, but still a huge chasm for us to cross.
So trust and then knowing your consumer and having that data so you can personalize the experience. Love it. Robert?
Yeah, absolutely agree with Anthony on those points. We have a bit of an unfair advantage at Banner Aetna in that we are in a joint venture with the delivery system, with Banner Health. in Phoenix. And so we are aligned in every way, 50% ownership by Banner and 50% ownership by Aetna, an independently licensed insurance company. So that gives us flexibility to try new things, but it also helps us establish that trust that is Anthony's talking about. Now, it's not a given. We still have to work to earn it. But at least the incentives are well aligned, and that is a key to moving us forward, there's no doubt. And one of the premises of Banner Aetna in our formation was that many of the roles that are filled today by insurance companies actually ought to be done on the delivery side. So we've done some creative things, like much of our outpatient care management is now delivered by Banner Health. We have something called the multidisciplinary care team that focuses on high risk and rising risk patients. And that team, which includes doctors, pharmacists, nutritionists, behavioral health specialists, that team can wrap services around those at highest risk. That's run by Banner. For Banner Aetna. Prior authorization, about 50% of that now is done by Banner Health physicians. And you might ask, well, is that the fox watching the hen house? And the answer is no, because they are aligned in terms of the desire for the company as a whole to do well. So they're prudent and thoughtful. And what we've discovered is there's very little difference between what Banner Health physicians decide and what Aetna physicians decide when it comes to UM. We would love, as Anthony suggests, to gut prior auth and come up with a front-end knowledge management system so that we're not doing the weeks of delay on the back end where members show up for a study and it hasn't been approved yet. We would love to have front-end help for the docs so that they understand exactly what is going on. And then you add to that the complication of spreading that across a clinically integrated network, not employed by Banner, but affiliated with Banner and part of our network. And for those docs, we have a pilot ongoing with a digital strategy that has pre-visit forms fill out. We'll give you a virtual waiting room. We'll let you know where you are in line, what's going on, and then after visit, follow up with you, et cetera. And all of those data can be collected in a single location. So we're not just going to be working on claims. Ultimately, with the help of a couple of companies, we'll be looking at a 360 view of the patient with claims and medical information.
That's terrific. And a reminder to the 50,000 viewers, you could submit Q&A, and I'm going to address one of them because I think this is actually a really good one. So one of the themes that you guys kept addressing is trust, community, physician-patient relationship, and that you could use data and AI to develop a better relationship with people because that you could build that trust because you know things about them. There's a great question from Louisa. The question is, how do you ensure that doctors or nurses or other care providers are capable and interested in creating these relationships, specifically addressing burnout? Because to put you guys on the hot seat, I'd argue that as a physician, I had to use an EMR. EMRs became an interface between me and my patients. It sometimes impacted developing that trust. And then I had to do a lot of things, especially with documentation, just to satisfy the insurer. So now that we've given you the power, you have all the data, you obviously have all the dollars, what could you be doing to give physicians some of this power back so that they can invest in these relationships and continue to build trust, going back to what maybe we had in the 30s or 40s, where you were really that, trust the doctor and their healthcare team was that trusted source of care. Anthony, why don't I start with you?
Yeah, so one of the, when I was a doctor, not a good doctor, but when I saw patients I enjoyed, it always, made my day and I enjoyed it more versus the patient that was always a big pain in my butt. And so what we try to do now is match the doctors to the right member or patient. So we're doing this with a large academic institution today where we built out a smart speaker skill for them using the Amazon smart speaker. And so now when you use their skill, and it's an all-payer solution to find a doctor, and if it is an Anthem member or an Elevance member, we actually pull up all the information and then we bounce that up against the database that we have among their doctors, and then we'll match them. So that now the doctor comes in, and if Robert sees the patient and they happen to be from the same, their ancestry, same geography back in India, you have these commonalities that you start bonding with. And so again, it's about engineering it. And by the way, if you went to our directory, you know what? We don't serve up the nearest doctor just by geography or language. No, we're curating that behind the scenes using insight so that now the doctor and the patient or the member has a better experience. And then that's how we all win.
Awesome. Everything with you goes back to dating, Anthony. Robert, what about you?
Yeah, I am a strong believer that the vast majority of physicians are internally motivated to provide excellent care, and that the real challenge and the cause of physician burnout, and there are numerous, but one of the major causes is in fee-for-service models or RVU-based models, physicians have lost autonomy and time. They really don't have time to spend with patients that's necessary, not only to completely understand the disease process, but also to establish a relationship. That doesn't happen in 10 rushed minutes, in a paper gown. It takes time to establish that. And so, over the long term, that's what we're interested in doing. How do we free up time for physicians by making their job easier? Sometimes that may mean using scribes, and there are companies that are working on and have almost perfected the art of the ambient scribe, basically the electronic scribe in the room that listens to the conversation, creates a note that can then be quickly edited by the physician. But I agree with you. We have to get away from the tool itself being the focus and focus on the relationship between the caregiver and the patient. And if we focus on that and create tools that support that and give that enough room to breathe, then we can recreate, I think, the sense of caring and trust that I saw growing up with my dad as a physician. Why did that happen? Well, he had time. He had time to talk to folks and understand what their issues were and to relate to them. And not every patient he saw was like him, nor did he necessarily like them. But they developed a therapeutic relationship that was highly effective because he cared and he had the time to do that. Americans value care above anything else in the healthcare system. They want to know that you're interested in what happens to them and that you care enough to take the time to listen and to strategize together on, what do we do from here? That's what we value, and that's what we're trying to pull back in.
Great. I'd love to hear that answer. Talk to me a little bit about, and we've touched this a bit, you guys are willing to adopt digital therapeutics, you're willing to give it to physicians, you're willing to reimburse it. What do you think some of the barriers to mass adoption, like blood pressure medicines, antidepressants, like mass adoption? How do we get mass adoption for digital therapeutics? Or the opposite is like, what's preventing mass adoption? Anthony, you look like you have the answer. Go first.
Well, even if I didn't, I'd make it up. So here's my made up. So from our experience, the mass adoption is number one, getting them to download or even to use the microsite, because a lot of people just maybe not comfortable with the technology and they don't trust it. So for instance, even with maternity, we text these Medicaid maternity moms, right? They're very tech savvy. Still, when it comes across, we try to establish, hey, this is Elevance, and we, get them to authenticate. But they're skeptical because number one, they don't know if it's spam or not. So once you get beyond that, number two, they're skeptical because they want to start talking with somebody, and some people, especially our seniors, prefer to have those conversations. So what we learned from that is we have a hybrid program where you always have that button in the top that you can click on, and then you can talk virtually. And then we also always really prefer video because then it humanizes us. And so you can see the body language, the intonation, so that we have a hybrid approach. Text,
for sure,
meeting with digital, but quickly being able to back up with a human, with the voice, with the picture.
Excellent.
And so we
Robert?
also include their bios too. So when we reach out, every nurse sends their bio so that if Robert gets a text from us, he can click on it and see actually who Anthony, the nurse, is, and a little bit about that nurse that's assigned to him.
Yeah, let me make a quick comment on that, and I think Anthony's absolutely right. One of the things that that we're finding is that when it is the physician's office that advocates adoption, we get a much better success rate than when it's even the insurance company with the delivery system's name in it is not as effective as a physician or their office reaching out. And we know this because of our pilot, as I mentioned earlier, with all of the stuff that we developed during the pandemic to make it easier for caregivers to stay safe and patients to stay safe. We know that even in the West Valley, where the average age is in the 80s in some of these practices, there's good adoption of the electronics when they're useful and when the recommendation comes from their physician. And so that's why the audience of physicians is so critical. Those are the folks that we need to convince that these digital therapeutics have value and that these strategies are really being developed now as tools to support the relationship instead of get in the middle of it. And that's the whole key right there is make sure that the tools are designed to support that relationship, not interfere with it.
That's great. I want to get to some of the questions in the chat so we could address some of the audience questions. This one has 8 votes. It's a tricky one, and I think it's Verta related in a way. But what do you see as some challenges to get a member to own their own habits and outcomes? So somebody who has chronic lung disease, who's a smoker, somebody who's obese with diabetes, like with 1 or 2 words, what are a couple of barriers to getting somebody to say like, okay, it's my turn to reverse this and I'm going to take control? Robert, 1 or 2 things that block them.
Well, first of all, you have to ask them. I don't know how many thinkers are going to have to reteach us this lesson as we go forward, starting with Hayek on markets, and you can go to Deming on manufacturing and all the way to more recently is wisdom is where the rubber meets the road. And in order to help members change what they do, we have to understand, first of all, why they're doing what they're doing and what the barriers are to that change. And that's part of the magic of the process of onboarding. And certainly Verta does a pretty good job of that, I think. It's a comprehensive way of thinking about, what stands between you and success. And then understanding what are those things that are motivating to that individual person. What are those things that will actually help get them there? It's possible to understand motivations much more deeply than we typically do in our day-to-day relationships. And it's also important that we understand what people's abilities are. And when those two line up, ability and motivation, that's when change can happen. And that's when it's important to double down with the support and help people get there. I think we're learning a lot about human behavior, and I think all of that is going to serve us well in helping folks meet their goals in terms of their why. Why would it benefit you to be healthier? What is it that you want to do with your life or your health? Why is it important to you? And if we can support that, then people can change. We've shown that.
Yeah, for sure. Anthony, any thoughts on that one?
Yeah, so it's easier said than done, but at our company, what we do is that, like I share with you, the different personality types in terms of how we talk to people, even how we write emails to them, it's based on their personality so that we can connect with them. And that's really a big part of it. It's like being able to resonate with people and not coming across generic, which is one flavor. And that's a lot of programs are very generic, and it comes down to mass personalization. And so we engineer that in a lot of ways. So even with just when you call in, the intonation, we capture that. So voice is a data stream. And then we combine that with claims data and non-claims information. And then we build a profile on you. And then that's how we help the doctors engage. And we share that with providers.
That's great. This one's an interesting one. There's a lot of entrepreneurs who are listening, as well as a lot of purchasers. And my guess is there's an entrepreneur out there who could go raise $100 million to try to reverse some disease that your massive companies would never put $100 million towards. And so what ends up happening is we're having a plethora, like literally thousands of digital point solutions. What's your guys' stance on point solutions versus platforms? Good idea, bad idea? Should people be looking at these solutions? How do you guys look at this? And then if you do like point solutions, how are you as large organizations trying to pull it together? Sort of like, Robert, when you talked about your digital formulary. Anthony, why don't you start?
Yeah, so we're highly protective of the ecosystem that we want to create. So that's why we highly prefer not to have these one-offs and to engineer that experience internally. You know, we're a larger company, not a single state blues as an example. So we do have the resources to be able to leverage that. And so similar to the platforms when you get on, when you're searching, right? And nowadays people search and they get on Amazon to search first. That's the power of an ecosystem that can keep somebody in and then help them to better health. Because, for instance, we're multi-line carrier. So then when somebody loses their Medicaid, they can then, and they get a job, they're still on a commercial. Yeah. And so that's how we look at it longitudinally as we engineer this ecosystem. Very critical to our success.
Robert, point solutions, how do you bring them inside?
Yeah, you know, that's a great question, and sometimes it can be overwhelming. Certainly, it can be overwhelming to members and to patients to have this array of point solutions that are disconnected. Well, one of the things that we do is we insist on a degree of integration with the existing infrastructure of care delivery in the network. In other words, there has to be exchange of information between whatever point solution we happen to think is a huge step forward. On the other hand, I will tell you that innovation often happens in this way. I see point solutions that are highly effective and really change the market in some way as incredibly useful. And the problem is you've got to have a whole bunch of point solutions to find one of those unicorns that actually understands it and gets it right. And so I think that process is healthy to some extent. But ultimately, what I would like to see is an integrated whole so that all of those are just tools that support the relationship between a member and their care team. And that care team has the ability to use all of those tools in an integrated and effective way.
I love it. So we're out of time. We're going to go over by 1 minute, and in one breath, I'd like you to give a piece of advice to our audience. So we went through an era of disease management. Huge focus of the 90s and 2000s was on prevention. Let's say we're going into the age of reversal. One breath, what advice do you give to the audience on reversing chronic disease? Anthony?
I think my one word is personalization, and that's key from our experience, is to bring it down to the individual.
Robert?
Curiosity, both from the member standpoint and from the healthcare system standpoint. Stay curious, do your homework, and the future will be revealed.
I love it. Robert and Anthony, thank you very much. This was a great panel. To those who are listening, focus on reversal. There are many diseases that can be reversed with the right infrastructure, technology, patient motivation, as well as medicine. So good luck on our journey, and let's kick off that moonshot on reversing chronic disease. Thank you guys very much. Back to you, Verda.
Thank you.